Good morning. I'm here to present my study on relevance, strategies, and challenges of school vision screening. As we all know, the visual problems in childhood has a negative impact on socio-economic aspect and academic life of a child's life. Uncorrected refractive error is a leading cause of vision impairment worldwide. So, active vision screening helps to determine the defects and early intervention can happen on time. On reviewing literature, a systematic review, it is shown that the prevalence of refractive error was 11% in India, with myopia being 8%, astigmatism 3%, hyperopia 1%. My aim was to find out the relevance, compare two strategies, and analyze the challenges of school vision screening program in urban area of Ernakulam and Thrissur districts of Kerala. My primary objective was to screen the school-going children and find out the total number of children with refractive error and newly detected refractive error, and also to compare two strategies, that are screening by trained teachers and screening by professional optometrists. Finally, document the challenges of school vision screening program by finding out the follow-up dropout reasons. It was a prospective observation cohort study including 325 children of 6 to 18 years conducted at a school vision screening camp on a duration of 6 months. I included school-going children of 6 to 18 years age and excluded children who were absent during program and children with pre-existing ocular mobilities, children with lack of consent for cycloplegic refraction. Visual acuity screening done by a pocket vision screener of optotype at 3-meter distance. Teachers were given vision screening training prior by a trained optometrist with the same pocket vision screener used by the optometrist. All participants present at school underwent primary screening conducted by teachers followed by optometrists. 6/9 is considered as normal vision, 6/12 or worse as screening failure, and all children were referred for detailed ophthalmic evaluation in the tertiary center. And also finally torchlight examination was done. The refractive error is recorded as spherical equivalent, and objective refraction was done and with streak retinoscope, and also subjective refraction done as a gold standard. Cycloplegic refraction with 1% cyclopentylate and 1% tropicamide was done. All the children were given follow-up advice, and a phone call was done to the parent or guardian of the child to evaluate the reason for follow-up dropout after a period of 3 months with this telephonic questionnaire. And teachers reported 25 children having refractive error. Optometrists reported 21 children having refractive error. Gold standard method concluded that it was 21 children with a refractive error, so the prevalence was 6.5%, in which myopia being more common than hypermetropia. So, teachers comparing between the teachers and optometrists and gold standard method, the teachers showed sensitivity of 100% with a specificity 98.7%. Two children were identified having newly detected. Reason for follow-up dropout mainly was due to lack of awareness. On comparing other studies, newly detected refractive errors 1.1% over 91,000 students, which is almost comparable with our study. And trained teachers could identify children with low vision, but false positive rate was very high. That was also comparable with my study. And follow-up dropout reason was mainly due to the inconvenience for visit and limited awareness of early interventions benefits with the lower income families. That shows less follow-up. My limitation of my study was it was a small sample size. Follow-up dropout reason was assessed with a telephonic questionnaire that introduced recall bias, and the follow-up period was short, and I also used spherical equivalent to define the refractive error that underestimate the astigmatism. So I conclude that refractive error prevalence was 6.5% among school children with myopia more common than hypermetropia. Newly detected cases underscores the importance of regular vision screening. Teachers can be included as a primary vision screener at school. The major cause of follow-up dropout was lack of awareness. That points to the necessity of stronger counseling and sensitive initiatives. Thank you.
So, in the conclusion, your purpose of the study, it's not fulfilled to compare, analyze between the two strategies. You have not commented upon that.
I compared the teachers with the professional optometrist. So I'm telling that teachers can be included as a primary vision screener if they get good training by professional optometrist.
Student population is too much, and the trained optometrist is very minimal. No, when you compare these numbers, they are very not. If you want that all only optometrist has to do, then it's not possible. But when you add teachers into the loop, that teachers will be a step where they'll do screening and pick up cases. You yourself said a lot of false positives will be there. Let it be. Let it be. They shouldn't miss something. They can as well over predict on somebody. And all these will be secondarily checked by the optometrist. I'm not sure whether they are comparables. You are trying to compare an apple and an orange. The teachers doing it is screening. The optometrist doing it is treatment. So they are two different aspects. So that cannot be compared. Individually, you can test teachers testing on school children. What is the data? How long they are doing? How much they are getting? For example, every year annually, if the school children are being checked, somebody is missed at 5th standard and is picked it up at 6th standard. Then you can say like these are the miss people who get missed. And this dropouts, I don't understand. They are all school going children only. No, there will not be a dropout. They'll be in the school only. No, they are getting dropped out from where?
We advised follow up in our tertiary center. Some of the
That will be like access and other issues. That will be non-medical issues which is affecting. Probably the child didn't have access to your center, you are far away from them, or they didn't have money to come to your place. Those will be the factors. It's not medical factor which is often. So that is also not a comparison.